Please help spread the message of frequency-specific microcurrent by clicking on the like button. You can subscribe to us on YouTube or any podcast app. If you have any questions, please leave them in the comments. You can find the podcast transcription at frequencyspecific.com, as well as more information about frequency-specific microcurrent.
Happy New Year.
Happy New Year. Merry Christmas. All the things.
Yes. We had a great kind of year in review, the last podcast that we had. And of course, after we got off, I thought of all these other things that we needed to, my favorite word, unpack before the year ends. But you know what? We'll just unpack them as we go for 2025.
Okay. Things to unpack.
There's always things to unpack. The more I get comfortable treating a certain condition, the more I get outliers that come in that are not outliers. Maybe they're the new exception to the rule, that I have to take pause and say, okay, what am I supposed to see here? What am I supposed to learn here? How can I see the shoulder different? Because I have had a fast and furious start to shoulders in 2025. The universe heard my love affair for the shoulder. It heard me talking about frozen shoulder wasn't that hard.
Yeah, be careful what you wish for. That should be in the small print in the course someplace. And you know my love affair with the sacroiliac joint?
Yes.
Had a patient last week, nerve pain down both her legs.
Okay. Back or the front?
Both. Basically, L1, 2, 3, 4, 5, S1 and S2 on the right, L2, 3, 4, 5, S1 on the left. And she said, yes, I have an MRI that says I have disc bulges in my low back. I treated for nerve pain. It went away briefly. Treated for disc repair. And then the next day, she brought in her MRI report. There were no disc bulges. She had a 1 millimeter bulge at L5, S1. And I went, everybody has a 1 millimeter bulge at L5, S1, and that doesn't account for L1, 2, 3, and 4.
Right.
And then I said, tell me again about what that nature path did to your femur on a drop table. And then what she did the next week to your trunk and pelvis on the other side, pulled on her left arm and held her trunk and pelvis in place, and then pulled on her left arm in rotation and flexion. And then I stress tested both SI joints, and they moved too much, and they both hurt. And I thought to myself, it can't be this easy. And without treating any nerve pain, just treating for an hour and 20 minutes on torn and broken in the ligaments and torn and broken in the connective tissue, back to front across the SI joint, the nerve pain in her legs went away. Oh, torn and broken in the joint capsule too. Yeah, I missed it.
You didn't miss it for long, though. That was
only because disc repair and nerve pain always works if it's a disc.
right. And so you said it did work, but just briefly.
Yeah.
Don't you think it's funny that you mentioned this? That's part of the list today, because low back pain consistently makes the top 5 most common complaints in US healthcare.
Yeah.
Everybody has low back pain, whether they're young athletes or octogenarians. It affects everybody. And we always, to your point, you just said everybody has a disc at L5, S1. There's a time and a place to get really excited about imaging, and there's a time and a place to get excited about imaging. When somebody comes in and they says, oh my God, look at my disc. And said, well, if you imaged everybody, especially over the age of 35, we're going to see degeneration. The low back pain program that is on the custom care is phenomenal, because it's this all-encompassing menagerie of the wear and tear in the annulus that everybody has, especially active people that are prone to that compression and rotation and shear forces in the disc. I think that's always a good place to start, especially when we don't have imaging and we don't know. And it can take the pain down briefly because we
Well,
all have these pathology, right?
and the low back pain protocol is mostly facets. Low back pain is always facets. Discs don't cause low back pain. Maybe
Right.
a little bit of low back pain, but mostly discs cause leg pain, nerve pain.
Right.
So the low back pain protocol is 40 minutes of facets and
Right.
10 minutes of torn and broken in the annulus. What fooled me was she didn't have a mechanism of injury that I recognized. I'm used to it. By the time you finish the history, you should know what you're going to find, what you should do, and what you're going to find on the physical exam. There was no mechanism by which I would have thought somebody should tear an SI joint unless you have mold and other. She's not Ehlers-Danlos, so she's not hypermobile. But if a naturopath who has 1/4 of manual therapy adjusts you on a drop table and puts her hand on your AIIS and your femur, so on your iliac crest and your femoral head, and drops on it.
So we'll talk for lay people. Number one, a drop table
Oh, yeah.
is exclusively, I'm not sure even if it's exclusive. I've been to many different um, health practitioners that use drop table adjustments that are not chiropractors, but they're tables that drop in certain areas to provide adjustments. Is
Well,
that
it gives you a controlled impulse that's fairly shallow.
Mhm.
It never raises up more than about an inch, inch and a half. And then this other movement she did on the left, it occurred to me that it could have created shear forces at a disc, but to tear the upper part of the SI joint. So when I treated her SI joints and then taped her SI joints, she left with her came in with her pain at a 7, left with her pain at a 1, treating the SI joints, and no
And
burning pain down her legs.
that was quite bilateral too.
Very bilateral. And it's okay.
I want to put you on the spot, but what are your thoughts on compression shorts and something like that instead of taping, or to merge from taping to, because the compression shorts that we used to have in Canada were very good for stabilizing SI. So the chiropractic clinic that I worked at, we had sold them with good results, but
Chiropractors use sacroiliac belts. So
Mhm.
the compression shorts may have the advantage of taking both iliums and shoving them inward.
Mhm.
Iliac belts, which are supposed to stabilize the SI joint, have the disadvantage of being able to wing the SI joint forward or back, and you can do either one. So I've never used compression shorts. I'm assuming the compression is lateral, and that
Mhm.
would just shove the SI joint inward, and it
Right.
should work. I've never used
So
them.
was thinking. The exciting part for me is when we go from identifying the pathology and treating the pathology. And then the fun for me comes doing the corrective exercise to get everything that has been either offline back online again. And my favorite analogy is getting the trifecta. So we're talking about the low back. So we're talking about the erector spinae, the glutes, and then the anterior musculature, the deep transverse abdominis, to get all three of those groups playing together in the sandbox again.
And having torn both of my SI joints over the years, one of them twice, all of the exercises I was given were for glute medius, glute minimus, the things that hold the SI joint together. Until the SI ligaments are stable, you don't get to do anything. So the other thing that diagnosis gave us was expectation. So people see us on the podcast and we tell these success stories and they think, oh, it's a 1 or 2 visit fix. And the expectation with an SI joint is it's 3 months before you expect any improvement. Now, if we're lucky and if she keeps it taped and if nothing unfortunate happens, maybe it's better in 6 weeks, like a sprain would be. But we're talking about the strongest ligaments and connective tissue in the body, the strongest joint in the body. It's a keystone, holds your upper body to your lower body. And 6 months on me, it was 12 months because I was traveling. The tape wasn't on all the time. I was lifting stuff. But when I got pain down my leg, I knew what it was. And it was like, oh, here we go. And the diagnosis is the gift and the expectation. No, this is not, you're not going to be better by next Tuesday. And you need to find a physical therapist that'll keep it taped when you go back to Arizona. And she had a bunch of other symptoms that she associated with mold and et cetera, and I did the vestibular screen because I do it on everybody, and her BIVSS score was 41. No, 26. Oops. Having to explain it to her and then seeing the blank look in her face, I came home, had dinner, and after dinner wrote up instructions, information about vestibular injuries for patients. So there is now a 3-page handout that will, as soon as I give it to Kevin, will be on the practitioner resource page because it talks about what causes them, what the symptoms are, and what the treatments are. And it included something I don't even talk about in the core, and that is legal. If you are stopped by a police officer for whatever reason, and as a matter of course, because he's doing it to everybody, because it's January 30th or whatever, he wants you to do a drunk driving field sobriety test. You can do the breathalyzer and blow 0, but they still want a field sobriety test. I couldn't pass one. I have Meniere's. So we have a friend that's a state patrol officer. And I took off my glasses and I said, go ahead, do a field sobriety test. And he did the thing with his finger and he said, your eyes bounce. I said, yes, I have Meniere's. And he said, now I want you to walk heel to toe. I said, I can't. I have Meniere's. And so the last instruction on that patient information is get a note from your doctor and put it in your wallet. We should have bracelets, but a note from an ENT, a note from me, a note from you, note from somebody that says this patient has a vestibular injury and will have these symptoms and cannot pass a field sobriety test.
Right.
Rely on the breathalyzer and hope for the best. It was interesting.
Yes, that will be a great resource for us to have because just like the vagus nerve, vestibular injuries are one of those things that we learned about and you learn about them and then you think, okay, whatever. And they appear on patient history forms, but they are so prevalent when you start looking for them. And we have the BIVSS to look at to help us with just giving us, it helps connect the dots and it gives patients this, what is the word I'm looking for?
Objective. Gives them a number. No?
Yeah, I think especially I'm searching more for when they don't know they have a vestibular injury. And then it's like I don't want to say relief, but it's that, okay, somebody identified and connected the dots for me.
There's a reason for all these symptoms because they have been diagnosed with all sorts of other conditions. Something else happened, speaking of vestibular injuries. Thank you very much.
Yeah.
We give the BIVSS to every new patient. So this patient came in, he's older, used to love to ride his bicycle, had an accident at some point, and he filled out the BIVSS and his score was like 8. Okay, that's negative. And then he came back in for his second visit and picked up the resonance effect in the waiting room and was reading it. And there was something, he had a positive vestibular screen with the bouncing of the eyes and the lateralization, but his BIVSS was 8. That's weird. I said, now that you've been trying, how long since you've read a book? Oh, I've been busy. How long since you've read a book? I don't know, 7 or 8 years. Now that you've been trying to read a book, do me a favor and fill out this form again. And the score was 41. And he simply avoided all of the things that would give him symptoms. So his scores were either seldom or never because he didn't do the family shopping and he never went to Costco and he read a book.
You start to protect yourself from those things that give you symptoms, like you said, Costco or Christmas shopping, right? We just came off of the holidays, and I don't know about you, but the people that are coming in having this extra layer of stress and thickness to their symptoms. And the people with vestibular injuries that are forced to go out and shop, and everything is more crowded, and that is intolerable, and it makes everything feel worse. I know for myself, even just clinically, saying that because of your vestibular injury, it's normal to have this and this and this. Oh, it is? Yeah, I actually got it. Can you write me a note that I can't do any more Christmas shopping? I'm like, sure. Santa will be a little late this year, or you'll
Yes.
have to do everything through Amazon, and that will be okay. You don't
Yeah.
need to, or just the recognition, I guess, is the word I'm looking for. And I think that's
Validation.
validation, recognition, something that people who, like you said, who have been giving all these little micro diagnoses of you have this, you have this, you have this, but have never put it all together.
Yeah, and for patients with shoulder problems, if they never have a reason to do this, they don't know that they can't do that.
Yeah.
It's like everything is this high, or they have a son or a husband or a taller partner who
Or another arm. So we see this a lot with frozen shoulder for on the driver's side, right? Where you would normally reach back with your left hand, grab your seatbelt and pull it across. Well, when the abduction and external rotation becomes painful, you'll just use your other arm, grab the seatbelt and pull it across.
Exactly.
So we're sneaky beings as humans.
Adaptive. We are adaptive creatures.
Yes, and I'm glad we are adaptive, but the adaptations that people have that is your job is for the practitioners that are listening, are to look for the adaptations, or we call them compensations, because especially people who are active or type A or who are stoic, there's so many different people that fall into the category of when they're injured, they don't slow down. They find a
Yes.
different way to get something done.
Exactly.
Running through the pain.
I'd say that's a good way to put it. Running through the pain. It's, I wonder who we know that might do that.
I don't know. We have a couple questions before we go forward. Someone was on an SI joint here that I wanted to talk about. Alf said, I had been seeing a woman with hypermobile SI joints persisting years later after being pregnant and delivery. Yes.
Oh dear. Yes. There's that.
There is that. So a lot of times when women are pregnant, everything becomes lax, right? So we hear our pelvises are always the culprit of what we would imagine to be very movable. And after delivery, it would be beautiful if things would just go back to symmetry, but that's not often the case. So when we do assessments with the SI joint, even monitoring like the pubic tubercles, we'll see a big difference. So there's that shear force. So what's happening at the front is also happening on the backside. So think of an SI joint that has been stuck in that kind of sheared position for so long and then has gone back. It's something that we absolutely see after delivery.
And when you see the pubic bone tilted and the SI joints tilted, I look at the psoas, especially if she had C-section. Bleeding causes scar tissue. There's the ureter. It's retroperitoneal, but some C-sections are less than tidy if everybody's in a hurry for a good
Right.
reason.
Right.
And it's so the psoas, when there's an SI joint or lax, or patients will say they're out of place, they're tilted, and we go in and work on the psoas, and the psoas is connected to the iliacus, and the iliacus is connected to the pelvis, and the psoas pulls the iliacus up, and so it's going to tilt the pelvis, and you can look at the pubic tubercles. And persisting years later after pregnancy and delivery, the persisting years later is they don't ever get treated, and they don't always, they're not always just pregnant once.
Right.
You have 3 children in 5 years, which is not out of the ordinary. Yes. And it's like your SI joints, about the time they heal or start to heal, you're pregnant again. And then everything goes squishy, so you can bear the child, then deliver the child. And then they start to heal. And then it depends on what you do with your legs, your hips. Do you love rollerblading as a way of relieving stress, or running as a way of relieving stress? So your SI joints are always being asked to do this.
Right.
And then you sit on the floor cross-legged, or sit on the floor playing with the kids, and the SI joints do that. When are they
Right.
going to heal?
Right. I'm going to add one more thing of just something that I had seen with a new patient a couple weeks ago. Similar story. So we have one baby and that's great. And then we get pregnant and we have another baby. So what are we doing with as we're pregnant, we've got a toddler propped up on our hip so that we can still, so that deviation that happens is so common with women that have had 1 to multiple babies, because going from infancy, the minute they're able to hold their head up, we shimmy that baby over onto the side of our hip. And that's not a great position for a healing pelvis.
That little iliac crest is a nice shelf, though.
Perfect. I'm not sure it was designed for babies, though.
It probably was, if you think about it.
And it'd be great in a perfect world if we would have the mindset to alternate those hips and use our
Yeah.
non-dominant hand once in a while, but that just doesn't happen.
Can't stir soup with my left hand. It's really not pretty.
Going with the whole female anatomy, Leaf had asked about an advancement in treating endometriosis.
I found pictures from Taiwan when we treated the girl that had abdominal adhesions from endometriosis. They had an ultrasound machine that also had a Doppler. They had ultrasound that picked up the scar tissue between the layers of the fascia, between the ovary and the tube. And then they turned the Doppler on and saw the inflammation, bright red all over the abdomen. So I treated the scar tissue, then treated 40 for inflammation. And with endometriosis, the frequency for the endometrium is 155. And if you ever get to see a surgery for endometriosis scar tissue, it's like somebody sprinkled paprika in the abdomen. There's little red spots everywhere. And in the textbooks, they call them chocolate cysts. and they look like they're big brown blood clots. They're not. They're paprika. It's everywhere. And so inflammation and 284 dissolve the blood clot in the endometrium. But if you're going to dissolve the blood clot, what's that going to do? It's going to start a bleeding. So you treat the inflammation, you treat the blood clot, but then you stop the bleeding, and you treat the scar tissue, because the endometrium bleeds every month when you have a period, because your endometrial lining just isn't just inside your uterus, it's paprika everywhere. And so they bleed, and that causes abdominal adhesions, including scarring in the vagus, the small bowel, the omentum. We have a wonderful case report on why you need to treat the omentum. That's coming up at the symposium. I'm excited.
Wonderful.
And so that's the biggest advancement, Leaf, is finding out that you need to take apart the scar tissue. Remember to include the vagus, scarring of the small bowel, scarring in the ovary, the tube, the uterus, the bladder. The thing with endometriosis is that because the scar tissue is everywhere, I have seen patients where the sigmoid colon was adhered to the left ovary and rolled over and scarred to the anterior surface of the bladder.
Wow.
So during the last 5-day core, we had 2 patients where you took the sigmoid and unglued it from the ovary, unglued it from the tube, but then we actually had to unglue everything from the top of the bladder to get the sigmoid back where it belonged. And then we checked the right side and found out that the same thing had happened to the cecum and the ascending colon. So
Wow.
everything gets folded into this ball of scar tissue in the middle. And then it's inflammatory because it bleeds every month. So inflammation, 284, chronic inflammation, but then finish with 18 and 62, stopping the bleeding in the arteries and the endometrium, 155. So it is an advancement, and it means I have yet one more thing on my to-do list, which is to do a webinar or a video on treating abdominal adhesions and what to look for. And the trick with that is finding a patient and stopping myself from treating them, waiting until we get a video camera, and then doing the lecture and the slides and the video on, because the manual technique is pretty flat-fingered and sensitive because it's so tender.
And you don't need, like everything else that I try to correct when we're teaching, is the pressure that you would normally need to pull apart adhesions or to do any type of visceral manipulation. You have to remove yourself and let the frequencies do all the heavy lifting. And you are just
yeah.
there to guide, because visceral work is one of the most painful things to visceral work, TMJ work. Without FSM, I'm not sure that I would even attempt it anymore, to be honest.
No. And the same thing in working on the subscap. I had a shoulder yesterday, and it's like Geneva Convention.
It shocks me because I've seen so many shoulders in the last 2 months. It's shocking. And I'm not exaggerating, gobsmacked, and I'm dumbfounded how many times these patients have never had their scapula assessed or treated.
Yeah. It's
Because the presentation is pain in the, and I'm, those of you who are just listening on the podcast, I'm pointing to my shoulder, the bony protuberance on the lateral side. The pain is here, and I'll start getting into their subscap. They said, no, the pain isn't in my armpit, it's here. I'm like, I understand that, but your scapula doesn't move.
and it is stuck in internal rotation and adduction. And the
Yep.
thing it won't do is external rotation and abduction, which is the reason this hurts. And
Right.
which means we have to fix, trust me. And then you put your fingers in their armpit and they understand that hurts way more than anything that
Yes.
they thought hurt in their shoulder. And then
Right.
they believe you.
And then they believe you. And then their shoulder blade starts moving, and the stress on the supraspinatus and the lateral and anterior delts just goes away because it can rest and it doesn't have to work so hard to lift the arm up anymore.
Bless, it's hard.
Try so hard. A couple more
It's so
questions
brave.
before we go any further. Leave. Thank you, Alv. Yes, Louise. Can one have vestibular issues without any recollection of injury? Are Prism glasses always indicated? Where can we access the assessment and how to do a proper vestibular exam?
Oh dear. It's
The first one, can anybody have a vestibular injury without memory of injury? And I say, heck yes.
oh yeah.
A lot, I think more often than not, they don't think of anything that caused the vestibular injury.
Yeah, I had an auto accident. And in this particular patient's case, she was a passenger in a car and they got hit on the driver's side front quarter and spun the car. And then the car ran into a post. So there's rotary motion and then a sudden stop. The vestibular system has a little bit of room, but it doesn't take much in the way of a pressure wave to injure the endolymphatic system. If the airbag goes off, if you have your head turned, I've had patients who had vestibular injuries just because they were looking in the rearview mirror, saw it coming, and that meant that they hit the mastoid right behind the ear when they were rear-ended. And the head whips. They don't connect anything with it. They know their neck hurts for 5 years afterwards, and nobody knows why. They know they have anxiety and digestive problems, and they've been diagnosed with H. pylori, mind you, without a positive hydrogen bacteria test, but that's another conversation. SIBO, because I'm nauseous all the time, and I have chronic fatigue. I'm better in the summer, but then the chronic fatigue really hits in the winter. Does it rain where you live in the winter? Yeah. Oh, okay. And that set of symptoms leads you down the vestibular path. And I've missed so many vestibular injuries that it is part of every new patient physical exam I do. Just take a tuning fork, put it in the middle of the head. If it lateralizes, they have a vestibular injury. They may or may not be hyperacoustic. And the saccades, the bouncing of the eyes, may be hard to pick out. If the injury happened when they were young, like before the age of 10, the brain learns to suppress the eye bouncing. Doesn't mean they don't have a vestibular injury, but you have to provoke it or fatigue it. And the way you know that they're suppressing it is they blink. They don't bounce, but they'll blink and jump back to the center. Interesting. And is there anything except Prism glasses? I actually had one FCOVD, Fellow of the College of Optometry and Visual Development, in a core, sat in the third row, and she said, I never prescribe Prism glasses. I always do, what do they call it? Vision therapy. And the purpose of vision therapy is to get your eyes to work anyway by forcing them to. I have some opinions about that. Number one, vestibular therapy or vision therapy makes me nauseous, and there's no circumstance under which I can be nauseated or motion sick 3 days a week. Number two, vision therapy is much more expensive than prism glasses. Prism glasses are more expensive than regular glasses. You can buy cheap frames and get prism lenses put in them, but vision therapy is much more expensive, takes longer, and sometimes it doesn't work. My patients, when I send them to the optometrist here, have to be in prism glasses for 3 to 6 months before they do vision therapy because the brain has to know what normal is.
Right.
How do you know what you're training for? Right? If you have never in your life run or you've never seen anybody run, you've only seen people walk, you have only walked. The concept of training for a marathon is completely foreign. So I wear prism glasses and I refuse to do vision therapy because I'm a brat.
I think you're a brat with good reason. Like you said, I think a lot of people just can't afford that sickness that accompanies the vision therapy. And I'm not saying to never do it. I'm sure I do know a lot of athletes that do it, but it is in tandem with other things. It is in the off season. It is an adjunct to a lot of things, not the only thing. So, yeah, no, prism glasses aren't always indicated, but I think especially you've got much more mileage with this because you have them yourself. It makes sense for, again, that safety that you're talking about. You can't train something that's foreign or that's something that is perceived to be damaging or to be symptom inducing.
And if your brain, that's the other thing, the BIVSS, which is the questionnaire we use for vestibular injuries, is the Brain Injury Visual System Symptom Questionnaire. So I had one patient that I sent to the FCOVD that I use, the optometrist I use for prism glasses. And she came back and she said he put me in vision therapy. She had had a brain scan at the Amen Clinic, and the lower portion of her temporal lobe on the injured side is missing. It's just not there. So I called the optometrist and he explained why he preferred vision therapy for this patient. I said, that's completely reasonable, but did she tell you about the brain scan? The part of her brain that you're trying to retrain does not exist. It is not functional. It is not absorbing or circulating or having a mitochondrial function. It's just gone, Tom. Oh, can we try prism glasses and see how they work? That always concerns me. I have to block it out. Is the fact that FSM practitioners know more about vestibular injuries than 97. I used to say 95. It's probably 97% of the MDs, including neurologists and neuro optometrists in this country. It's crazy. And it's just because I got lucky and happened to be around these three guys, and we all saw the same group of patients that were diagnosed with chronic fatigue. And that's
Right.
where I found out that 100% of these patients had vestibular injuries. Oh, okay. And they were seeing these three specialists. And that's where I learned about it. And then I started telling, and now I wish I could move it further forward in the core.
But you
You
need
have
to have it, I think, where it
Yeah.
is.
Exactly.
Yeah.
So do we have other questions?
Yeah. So Leaf, I just want to go back to Leaf's really quickly. He had asked, he said, in the buddy, I find no frequency for Omentum. So the Omentum is adipose. So we use 97 for Omentum.
And it's also very well vascularized, as you'll find out. And it has a lot of lymphatic tissue. So I have a patient or friend who had ovarian cancer. It was stage 2. It had not spread to the peritoneum, yay, but they took out her omentum because it has so much lymphatic tissue that if you were a cancer cell that was going to be picked up by the lymphatic system and from an ovary to a lymphatic tissue, it would get picked up so they took the omentum out.
Wow, fascinating. We talk a lot about the Omentum in the sports advanced course, and I told this story where there was a person that didn't understand the word Omentum, thought I had made it up. It was a Canadian term. And Dr. Heather was their anesthesiologist, was like, you need to learn about the Omentum. It is full of, it stores information, it stores toxicity. It's, like you said, very vascularized, lymphatic. So a lot of traffic goes through the omentum. So if you hadn't thought about using 97 when you're doing abdominal work, you're going to want to do it just thinking about what the omentum can store and hold and how much, like I said, traffic goes through the omentum.
And one of its functions, believe it or not, is to provide squishy things for the small intestine. So it sits down in between the loops of the small intestine. And that's where sclerosis in the adipose is the finishing touch to treating abdominal adhesions. You want the omentum to be slidey, glidey. And that's what 3 and 97 does.
Mm-hmm.
It's pretty fun.
Glidey, glidey. We do have another question. I might have to Google this one. Have you ever treated corticobasal disease?
Corticobasal that I know about is
I'm gonna Google search this really quick. Corticobasal syndrome, I'm guessing, also known as corticobasal degeneration, a rare brain disease that causes a gradual loss of nerve cells in the brain. Symptoms include movement problems, stiffness, slowed movement, difficulty controlling one side of the body, language problems, thinking behavior changes, memory problems. CBS is caused by a buildup of tau proteins in the brain, form harmful clumps in brain cells, could be due to a gene mutation on chromosome 17. CBS symptoms start on one side, spread to the other. It is an atypical Parkinsonism, which means it shares some features with Parkinson's disease, but it has a distinct characteristic. It is different because it is not responsive to levodopa.
right. And whereas Parkinson's presents as stiffness, I've only seen 2 or 3 CBS patients. It's movement and balance. Parkinson's is stiffness, like the face doesn't move. They have this mask. They have a resting tremor. Corticobasal doesn't have a tremor as far as I know, but they have trouble with balance, and they will have a similar complaint as Parkinson's. I keep falling. And then the ones I've seen were early towards mid-stage and problems with movement and balance. And I've never seen one that was advanced enough to include the verbal part. And I don't know what part of the brain. I think of it as a brainstem, cerebellar, headed towards the midbrain. So is it motor function where the language problem comes, or is it in the Broca's area where you turn thoughts?
Said yes, said motor.
Is what?
Motor.
Motor for the speech. Yeah. So it's like you can't make the words, the movement. So I just think of it as, yeah, it's something we can't fix. You can try that. The thing that I start the advanced with, the thought experiment about Alzheimer's, you could try that and change the tissues to the cerebellum, the medulla, the vagus, because vagus is part of the motor part of the mouth, maybe. But it's a bad diagnosis. It's just bad. concussion in vagus, a good support system. They will be accompanied by a caregiver and make sure the caregiver gets treated. It's one of those. It's just not, we don't always get to vote, and it's not always pretty.
Yes. Okay. Dana, anecdotal low back pain relief by magnesium citrate laxative. I've also been using FSM, but the addition of magnesium citrate laxative seemed to have an instant relief effect. Could this be synergistic with FSM? Interesting.
Magnesium citrate is magnesium that is not absorbed. Magnesium glycinate and magnesium malate are absorbed. Citrate is not. So it concentrates in the stool, and the body seeks balance. So with all this magnesium in the stool it's going through, the colon's job is to reabsorb water. When there's all this magnesium on the inside and not that much magnesium on the outside, it doesn't absorb the water. So it makes the stool softer. So magnesium citrate is a laxative. Could the low back pain have had something to do with constipation? That's not completely out of the question. And then you'd start asking about, was there an abdominal surgery? What happened before the low back pain? Was there an abdominal surgery? Was there magnesium oxide is the other one that's not absorbed. Thank you, Lynn. And so the link is the magnesium citrate operates as a laxative. So what is there about being constipated that made the low back pain worse? Because magnesium, it's not as if, it's okay, your information is different than mine, Lynn, but that's okay. Magnesium citrate is not something you use to make your muscles feel better. That's glycinate or malate. Glycinate is good for the brain, the heart, the muscles. Malate is specific for the muscles. Oxide is not something I've ever used, and citrate was what was prescribed to me as a laxative. So if Lynn knows that citrate is, and the chelated forms, yes, it's what they're chelated with. So this is true. But anyway, so the link between the two is low back pain and constipation, especially if it's citrate. If the patient says, my low back pain got better when I took magnesium malate, then you go looking for muscles. If the patient says, my low back pain got better when I took magnesium citrate or oxide, I always think of oxide, makes me think of that stuff that you put on your nose, zinc oxide.
Zinc oxide.
Yeah, and I don't want to put that in my colon. So it's knowing that citrate is a laxative that takes you down what questions you ask. They could be synergistic, but how constipated has the patient been? Are there adhesions?
That's what I just jumped to instantly, is if there's relief in the bowel, there's less pressure, there's less tension. If there's adhesions, everything, you use that word, like the squishy, glidey, flowy, like how our organs are supposed to move. If there's stool compacted in the large intestine, like that is going to cause low back pain.
Yeah.
So I wonder if that'd be interesting.
And just the weight of it. If you think of how much there could be sitting down there that your low back muscles have to hold up.
Yeah.
Thing.
Interesting. Okay. There's that. There's a couple other comments that popped in. I just want to make sure. Carrie had written, we'll try to get to as much as we can. 5 minutes. I have a complicated client. One of her mysteries is when she exercises, taking a walk or anything, she becomes very fatigued after 15 minutes, feels so miserable. She has to go home, lie down, wait for it to pass. She calls it malaise.
Where are we?
It's in the Q&A.
Yeah.
halfway down. I'll delete some of these ones that we talked about. So that's done.
Yeah, Parkinson's is a substantia nigra. Yeah. 3 C-sections 7 years ago, adhesions from the surgery, exacerbating low back pain by constipation. Yay, Dana. Woohoo. Okay.
So it's Carrie's question.
Okay. Complicated, one of her mysteries. When she exercises, very fatigued. Okay. If that was my patient, sure, the next step would be a cardiologist. Right? Does that make
Yes.
sense?
Yes.
Goes for a walk for 15 minutes and becomes very fatigued. Once she has a negative or normal EKG, then we can have a conversation. But until then, it's not safe. Magnesium chloride. Okay. Careful with DMSO leaf. DMSO is dimethyl sulf something or other. It is a carrier that'll take anything that it is mixed with or touches through the skin into the body. It's a great way to poison. I watch mysteries. So it's a great way to poison somebody by putting a poison on the handle of their cane with DMSO. They put their hand on the cane, the poison is absorbed, and they're dead before they hit the front door. So DMSO, when you use it, so they found out by accident, because it's a solvent, they found out by accident that it made low back pain better. That was interesting. And over the last 40 years, 50 years, 60 years, when you use DMSO, you use a clean, sterile tongue depressor to put the DMSO on your skin, and you add whatever you're going to add to the DMSO and mix it on the skin and then spread it around with the tongue depressor, because your other hand has been on the doorknob, was washed with soap, might have hand lotion on it. Think about what complete and instant absorption of anything it carries into the skin. Makes you think.
Yes. A couple more comments about magnesium. Who thought this would have been such a hot topic tonight?
Yeah.
Tad had written a couple things here.
Okay. I hadn't heard that, but if that says so, I'm willing to believe it.
Louise had written something about in acupuncture, L5 level is the SHU point for large intestine.
Ah, okay then. Yes. Alkaline uses up HCl. Yeah, I don't like magnesium oxide. And magnesium citrate was more bioavailable. Okay, you got to prove that one to me, Alf.
I think he put an article. He cited an article.
I see it, and it doesn't make any sense. It's not absorbed. It's bioavailable means it's available to the system. And that means it's absorbed, and it's okay. Then how is it such a good laxative? And magnesium glycinate is not, nor is magnesium malate. Who knew magnesium would be such a hot topic?
I don't know.
I don't either. I had so much fun today.
Yeah, it always goes by way too fast. And
I got to go to the trophy shop and order the awards for the advanced and symposium.
Excellent segue.
We have the Ruth Johnston Award going to 2 people this year. It's only the 3rd time that's happened.
Wow.
And we have a LEAP Award, which you might recognize.
Yes.
So that award has only been given out twice before.
Wow.
You got one, Jody Adams got one.
Yes.
And now we have one other surprise guest.
I love the awards. I love watching it. People take so much pride in getting them. it's such a wonderful community to be a part of and to cheer each other on and just to see the leaps and bounds. So like the LEAP Award is so aptly named, as is the Ruth Johnson Award. That might be one of my favorite awards that I've ever got because of just the person that I feel I know because of the stories you've told.
Yeah. And the other people that get it. It's a sort of a who's who, Jeff Bland and Christy Hughes and George Douglas and the people that have gotten it are the ones that make FSM progress.
Mhm.
And the leap are people that just leap.
Yeah.
It's like that scene in Raiders of the Lost Ark.
Yeah.
It gets to the edge of the cliff.
Yes.
There's nothing here. It says I'm supposed to set, okay. And he goes like that and takes the step.
Yeah, exactly. But you have that belief somewhere deep down that not only is it going to all be all right, but like life is about to change.
Yeah. Yeah. That's a good way to end the day.
Wonderful way to end. So excited about the Advanced and seeing everybody in March, the big old family reunion that we get to have. So if you haven't signed up for the Advanced, do it.
It's going to be fun.
Always fun. And keep the questions coming. Happy New Year to everybody that tunes in and listens to us and comes live. It's so much fun every Wednesday to be a part of this. So grateful.
Yep.
And with that, we will see you all next Wednesday.
See you next Wednesday.
Bye, everybody.
Bye.
The Frequency Specific Microcurrent podcast has been produced by Frequency Specific Seminars for entertainment, educational, and information purposes only. The information and opinion provided in the podcast are not medical advice, do not create any type of doctor-patient relationship, and unless expressly stated, do not reflect the opinions of its affiliates, subsidiaries, or sponsors, or the hosts, or any of the podcast guests or affiliated professional organizations. No person should act or refrain from acting on the basis of the content provided in any podcast without first seeking appropriate medical advice and counseling. No information provided in any podcast should be used as a substitute for personalized medical advice and counseling. FSS expressly disclaims any and all liability relating to any actions taken or not taken based on any contents of this podcast.